Okay, what else? Coronary artery disease. Hypertension accelerates coronary artery disease. Can you think of anything else?
Possible organ damage. Organ damage later.
Or multiple organ damage. So retinopathy, yes. Need more space. Okay. Have you heard of, actually we'll get to that part later. What about kidneys? Is there vasculature in the kidneys? And that vasculature can get damaged, right? Okay, so kidneys. Kidneys. Try not to go off screen. Okay, so it's defined as a blood pressure greater than 140/90. So when we treat patients, what is our goal? Is the goal 120/80 pre-hypertension or less than 140/90? Less than 140/90. And after patients have been on meds for a year, they may choose to start tapering meds if their blood pressure is well controlled. All right. Next. All right, did you guys look at this algorithm? It's kind of neat. What did you notice about it? Did you notice there are some differences based on age? So for age over 80, what's the target? Look at the top. Less than 150/90 versus for a younger person, we're going to go for less than 140/90, okay? Unless they're high risk, if the elderly person's high risk with diabetes or kidney disease, we'll still shoot for the 140/90. All right, so this is a great example of an algorithm. They also have algorithms for things like ACLS. And a lot of African American patients are started on what kind of blood pressure medication? Thiazides. It says calcium channel blocker or thiazide, but thiazide's the most common. And where else do we see thiazides? Over 60, they tend to put them on thiazides. And what about a young person who has hypertension, under 60? ACE or ARB. How do we tell what's an ACE inhibitor? What's the ending? Your pearls. Good. And what about ARBs? Sartan, like losartan? Good. And then we go down the line. If these aren't working, we add more drugs, right? So in the end, as you go down 2 to 3 rungs, everybody could end up on all of these. So those are really common ones you're going to see in the hospital. And also at the bottom, we see spironolactone and beta blockers if we need to go past the 3 or 4 listed here. Okay, and then what is 160/100 is called what? Stage 2 hypertension. And so what's the difference with that versus the stage 1? We want to start with 2 drugs, right? We want to be more aggressive. They're going to be higher risk for complications with that higher blood pressure. And then there's patients with special cases. They're very complex with all these comorbidities, so they're going to see their specialist and they're going to help them dial in their treatment. By the way, what is the name of a kidney doctor? Do you know? Nephrologist, good. So those require special treatment. All right, moving on. Oh, I wanted to highlight something here. Thiazide diuretics. What is one of the major complications or potential complications, side effects? Hypokalemia. Oh, that's good to know for your test, lab test. What are some of the symptoms of hypokalemia? And what is the value for hypokalemia? Less than what? 3.5. And so the symptoms? Thirst, lethargy, weakness. What else? There's one thing in particular I see, a couple things I don't see on the list. Muscle cramps. Good. What else?
Tingling in like the fingers.
Tingling in the fingers. Is that a side effect? I think a rarer one. Yeah. Very good. What about the heart? Arrhythmias? Okay. So if a patient has a potassium of, say, 2.5, what kind of monitoring should they have? Should be on a telemetry monitor, okay? Should be on a heart monitor. Okay, so thiazide diuretics, again, we could see problems with electrolytes, and in addition, sodium, magnesium, and chloride. And what are the loop diuretics? Lasix. What are we going to look for with that? Check the labs, check for low potassium, low sodium, low chloride. Okay. Watch, you're going to look at what on their chart related to ins and outs. Well, I kind of just told you, right? Fluid status related to ins and outs. Yeah. All right. And then what are the trade names of these? Because these are ones you'll see once in a while, especially I see this one quite a bit. So not the generic name, the trade name. Bumex and Demodex. Okay? All right. And then what do we have to be careful with spironolactone? Potassium sparing, good. And what other drugs could have additive effects if given with spironolactone? ACEs or ARBs. Okay. All right. And then we have thiazide and potassium sparing combos, hydrochlorothiazide and triamterene. Don't see those quite as often. Okay. Right. Okay, ARBs. We talked about the ARBs can cause potassium retention. Calcium channel blockers. Nate, what is so amlodipine, I want to highlight something with that. Does that have a impact on heart rate versus cardizem? Minimal, if any. So cardizem I see used a lot for, in addition to hypertension, SVT and hypertension, and it does lower heart rate, so you need to check heart rate before you give that one. All right? It also has the benefit of helping with angina, calcium channel blockers in general. All right, you can go through these on your own. I want to highlight some more things before the case study. Any questions on the table? You want to know your contraindications, side effects. So if a patient has a decompensated heart failure, we may not choose to use calcium channel blockers, by the way. So if they have heart failure that's not managed well, that can be a no-no. Okay, beta blockers, Ruby's on beta blockers, right? What are we going to check before giving a beta blocker? Heart rate. What else? Blood pressure. And somebody looked this up yesterday. Hold for blood pressure less than what? What do you think? Systolic blood pressure. Actually, we looked it up. It's 100. And what about heart rate? Less than 60. Okay. Very good. So that's going to decrease the workload of the heart, decrease the oxygen consumption of the heart. Oh, how is labetalol different in its mechanism of action? So it works directly on the heart, and where else does it work? Works on the periphery, so it reverses the vasoconstriction in the periphery. So it has a dual effect. It's a combined alpha and beta blocker. Pretty cool. All right. Oh, what's the reason a lot of people will go off ACE inhibitors? Cough. A lot of elderly don't like it and they'll go off it because of the cough. What's another reason a lot of people go off blood pressure medicine? Cost. Cost, yeah, that could be cost prohibitive. So if you can do a single pill treatment, that tends to be better. And also the lowest cost med is the best. All right. So heart failure. With heart failure, there's a problem with either contracting or filling. So which is the contracting kind is systolic heart failure. And what is a normal ejection fraction? Percentage of blood ejected from the ventricle with each beat. 55 to 65. What's a borderline ejection fraction? Suboptimal. Around 40 to 55. Less than 40, you're really getting into the heart failure range. Okay? And then diastolic failure, do you have a normal ejection fraction with that? Yes, you do. But the heart can't fill properly, so even though you're ejecting the right percentage of blood, it's not enough blood to meet the demands of the body and meet the perfusion needs. Okay. Okay, right-sided failure. Right-sided failure means back up into what? Periphery and the systemic circulation, right? So you're going to see edema, you could see JVD, ascites. How do you think you track ascites?
Weight every day.
Weight is one, so daily weight is something you want to do for all heart failure patients. Serial measurements with a tape, and they often will do that. Okay. Also, you can see enlarged liver, so right upper quadrant might be full and tender. Poor appetite. Okay. Fatigue. Both left and right-sided failure have fatigue. And why do they also call it cor pulmonale? What can also cause right-sided failure? Hypertension in the lungs. So the vasculature in the lungs are clamped down. That puts backward pressure on the heart. And so that's another reason it's called cor pulmonale. Ooh, NCLEX hint. Reducing sodium restricts salt and water retention, reducing load in the vasculature. So salt restriction is a mainstay of heart failure management. All right. And left-sided failure, what are the forward and backward effects? Backward's going to go where? The lungs. What are you going to see? Pulmonary congestion. What are you going to hear? Crackles. Good. Okay. What are the forward effects? Decreased perfusion. So what do you think that's going to do for thinking with somebody who's got severe heart failure? Could be confused, tired, restless. Okay. You also could have wheezes in the lungs for the backward effects. Tachypnea, elevated respiratory rate. Okay. Oh, did you notice his blue toes? Poor perfusion, all right? What is orthopnea? Positional, so you have to sit up, it's like the typical patient has to have 3 pillows to be able to breathe at night. So that's orthopnea, positional dyspnea, yep. Very good. You guys are, oh, we missed these graphic pictures. You guys didn't call me on that. Good thing we're after lunch, okay. Blood-tinged sputum is common. And then poor perfusion, we have cyanosis here. Lovely, lovely. Okay. 50% of heart failure patients are readmitted within 3 months. It's a pretty serious problem in our healthcare system. All right. I'm not going to go through this whole table because did you notice there's a lot of similarities between heart failure and hypertension management? What questions do you have? Ruby's on DIG, right? You'll want to study that one for sure. What are some signs of DIG toxicity? See if you remember the pull everywhere from the other day.
Halos around the lights.
Yellow halos in the vision. Anorexia, good. Weakness. Could have a very low heart rate. Good. What potentiates DIG toxicity? What electrolyte problem? Low potassium. Very good. So DIG is a positive inotrope. It increases cardiac contractility and hopefully cardiac output. All right. Let's see if there's anything else I want to say about this list. I'm going to watch renal function with your ACE inhibitors as well. How do we track renal function? Creatinine, good. Sometimes the bun will go up as well. What's the normal value for creatinine? About 0.8 to 2, I think it's milligrams per deciliter. That's a good one to memorize. All right. I remember the big heart failure admission trend after Thanksgiving. Any guesses why? Salt. They ate a bunch of gravy and stuffing, and they gained 8 pounds after Thanksgiving and got short of breath and had to go to the ED. Yeah. All right. Oh my goodness. We're going to get in your clinical groups. I think I'm on time within 3 minutes. So you're going to get in your clinical groups, and Canvas has a nice feature where I can open a document at a certain time. So I think this document is open as a Word document in Canvas right now, hopefully.
What's it under?
I think it says heart failure case study.
But I know, but which, module, grades, assignment?
It's under the module for week 1. Yeah.
That's open.
Okay. And then if you get through one, there's a hypertension one as well. Or the hypertension one you can do at home too if you don't get through this one. And then at 2:25 we'll debrief. Be ready to give answers randomly, and then we'll have our exam soft training. So any questions about theory or lab at this point? Or today? Yeah.
So we were talking about how anorexia is an early sign of toxicity.
Uh-huh.
But when we're describing that to a patient, that comes with a lot of negative
Yeah.
connotations because
Yeah.
of anorexia nervosa.
Uh-huh.
So what's a better way to explain that to our patient?
Poor appetite.
Okay.
Yeah. Poor appetite. Yeah. Any other questions? Yeah.
Is there any other possible time to get into the skills lab besides office hours, or are we not allowed to be in there if there's not an instructor there?
Besides Saturday and Monday?
Yeah.
Can you talk to me? There's not a scheduled one at this point.
Okay.
If you have a special need because, I don't know, you're going to a wedding or something, you can talk to me. But
Oh, no, it's fine. No, I still wanted to go. I just wonder if there's
yeah.
actually. That's-
Well, I mean, it's just if you want quality instruction and people to be there, that's when people are going to be there. Yeah, let me think about that more.
Yeah, no worries.
All right, so you can leave class as long as you come back at 2:25. Go outside for all I care. Go to the lounge, or you can stay here.
And with our clinical groups?
With your clinical groups. Do you guys know your clinical groups now? Except for maybe the Friday people?
I like your cute. They're very bright.
You guys know notice the Providence flyer I posted? It's pretty fun. Pretty good study tool.
I'm having a hard time finding this one. I can find the course type class. Where can I find
You should have gotten a code in the book, and we don't normally track that. That normally you.
Oh, so I don't need it then start.
No.
Okay.
Normally you take a screenshot of the assignment and submit that as your file.
Okay.
For class.
I was like, I cannot find this code anywhere.
No
but
problem.
That makes sense.